ADHD is often stereotyped as a simple deficit in behavioral discipline or poor parenting. Clinically, it is an entirely different mechanism, a multifactorial neurodevelopmental disorder. The condition is rooted in the physical architecture of the brain, specifically structural and functional differences within neural networks responsible for executive functioning and regulation. This neural network model highlights the pathways that drive these regulatory functions. They rely heavily on two neurotransmitter systems, dopamine and noradrenaline. In ADHD, these chemical systems are chronically dysregulated, manifesting physically and cognitively in three distinct symptom branches: inattention, hyperactivity, and impulsivity. To accurately diagnose and manage this disorder, we have to look past surface-level behavioral quirks. We must rigorously apply the criteria of the DSM-5 to build an evidence-based clinical strategy. Understanding this neurobiological baseline is crucial. Any effective clinical treatment must target these specific chemical pathways to restore normal function, rather than merely punishing the resulting behaviors. The diagnostic process starts by establishing a persistent pattern of these core symptoms across specific cognitive domains. This matrix illustrates DSM-5's quantitative rules. For children, clinicians must identify 6 distinct symptoms to reach the threshold. As the brain matures, requirements recalibrate. For patients 17 and older, criteria require 5 documented symptoms. These symptoms cannot be fleeting. They must be continuously present for a minimum of 6 consecutive months. Furthermore, the observed behaviors must be statistically inappropriate for the patient's current developmental level. The timeline of origin is equally rigid. Several symptoms must exist prior to age 12. This rule applies even if the patient is being evaluated for the very first time as an adult. These strict numeric and temporal thresholds serve a specific protective function. They prevent clinicians from misdiagnosing a temporary reaction to stress or standard childhood development as a chronic clinical disorder. A true neurodevelopmental disorder does not turn on and off based on location. Symptoms isolated to a single environment do not qualify for an ADHD diagnosis. This Venn diagram demonstrates the multi-setting requirement. Functional impairment must be validated in 2 or more settings, such as at home, in the classroom, or at the workplace. When these criteria are met, the diagnosis is categorized into one of 3 distinct clinical presentations. The first is predominantly inattentive, characterized by chronic disorganization, forgetfulness, and a persistent inability to complete tasks. The second profile is predominantly hyperactive impulsive. These patients exhibit extreme physical restlessness, frequently interrupt others, and struggle to wait. The third is the combined presentation, where a patient meets the full symptom threshold across both domains. Relying on outdated templates for these presentations creates significant diagnostic blind spots, particularly concerning gender and age. ADHD is frequently missed in young girls. Their clinical presentation often skews heavily toward inattentive symptoms, like chronic daydreaming, rather than the overt, disruptive physical hyperactivity typically seen in boys. As patients age, hyperactivity evolves. In adults, it rarely looks like physical running or climbing. It internalizes as a chronic inner restlessness and a persistent inability to relax. Similarly, adult impulsivity shifts from childhood impatience into severe functional consequences. It drives poor occupational choices, risky behavior, and highly impulsive financial decisions. Rigid adherence to stereotypes, expecting every patient to look like the hyperactive schoolboy, causes clinicians to miss these masked cases.
Recognizing how presentations shift across demographics is critical for effective lifespan care. ADHD is a purely clinical diagnosis. There is no single definitive blood test, CT, or MRI scan that can confirm its presence. Instead, clinicians must rely on exhaustive histories, corroborated by standardized tools like the Vanderbilt or Conners reading scales. This filtering diagram represents differential diagnosis. A critical step is isolating true ADHD by screening out overlapping conditions like sleep disorders. In adults, clinicians must carefully differentiate impulsivity driven by ADHD from the manic phases of bipolar disorder. Furthermore, ADHD rarely exists in a vacuum. It frequently presents alongside comorbid conditions, including oppositional defiant disorder, anxiety disorders, and autism spectrum disorder. Mapping the differential diagnosis with high precision ensures that subsequent clinical interventions target the actual neurodevelopmental root, rather than mistakenly treating secondary or misidentified symptoms. This treatment pyramid shows that effective ADHD management is inherently multimodal. The foundation is psychoeducation, aligning the patient and family on the disorder's neurobiology, while establishing lifestyle routines like regular sleep schedules. The middle tier involves structured behavioral interventions. For pediatric patients, this means implementing clear reward systems, consistent consequences, and specific educational accommodations within the school environment. For adults, this behavioral tier often utilizes cognitive behavioral therapy. CBT is highly effective for managing executive dysfunction, improving poor time management, and building emotional regulation skills. At the apex of the management pyramid is targeted pharmacological treatment. Stimulant medications, such as methylphenidates and amphetamine-based options, serve as frontline tools. They work directly to improve core attention networks and suppress hyperactive and impulsive drives. When stimulants are inappropriate or ineffective, clinicians utilize non-stimulant alternatives like atomoxetine, glufosinate, or clonidine, selected based on the patient's specific clinical profile and side effect tolerances. Initiating pharmacotherapy mandates rigorous clinical monitoring. Doctors track changes in appetite and sleep and carefully monitor pediatric growth charts to ensure developmental milestones are met. This monitoring extends to cardiovascular metrics, requiring regular checks on heart rate and blood pressure, alongside evaluations for any mood shifts. Medication provides the baseline neurological capacity for focus. However, it is the behavioral and lifestyle interventions beneath it that provide the structural and organizational skills necessary to actually utilize that capacity. Viewing ADHD strictly as a childhood phase is clinically inaccurate. It is a lifelong trajectory where symptoms simply evolve, shifting from pediatric hyperactivity into complex adult executive dysfunction. This longitudinal graph plots age against functional impairment. Untreated, ADHD creates a compounding negative trajectory of chronic failures, but precise multimodal treatment shifts this trajectory, reducing the gap between a patient's potential and their actual performance. This restoration begins with an accurate clinical profile. By identifying the specific presentation through multi-source data, clinicians ensure that pharmaceutical and behavioral tools are applied to the correct neurodevelopmental targets. A rigorous, evidence-based approach addresses the underlying neurobiology, providing the functional stability a patient needs to secure their long-term quality of life.